Okay, well, our final speaker this morning is Lee Schwartzberg, who's Executive Director of the West Cancer Center and Professor in the University of Tennessee.
Well, good morning. I'd like to thank the organizers for the opportunity to be here today. And what I'm going to do is extend the excellent talks you just heard from Rami and Jed, and talk about the patient experience with immuno-oncology and the focus on three aspects of this: education, assessment, and access. And by way of introduction, I am not a patient. I'm an oncologist who has spent most of his career in the community focusing on patient care, clinical research, and patient engagement. And here are my disclosures. So the past year was a remarkable one for immuno-oncology in many respects. And this slide shows you what has happened since March 2015 with FDA approvals for drugs in this space. There were 9 approvals with 5 different drugs, 3 different diseases, some with companion diagnostics and some with complementary diagnostics, and approvals both for advanced disease and adjuvant therapy. This is really remarkable. If you look back a decade ago at FDA approvals, we were dealing in the community with 2 or 3 approvals of cancer drugs overall, not 9 just in one space, which doesn't reflect all the other approvals. So you can understand why, for both patients and for practitioners, there's an overwhelming amount of knowledge that needs to be integrated quickly in order to get these life-saving drugs to the patients that need them. So considering this, about a year and a half ago, the Association of Community Cancer Centers, ACCC, thought about starting a program to address what has turned out to be a tsunami of agents that are available now, and created the Institute for Clinical Immuno-Oncology. And the focus here, much like you heard from Jed, was to get information out to the practitioners, with the focus being not necessarily only on the providers, which was important, but also the full multidisciplinary team that takes care of patients. And it does take a village to take care of patients, and it includes not only the providers, but in the practice setting, the practice managers, the financial counselors, the navigators, the nurses, the social workers. So there were really 5 elements to the Institute of Clinical Immuno-Oncology, or ICLIO: clinical optimization, how to use the data that we've seen in the trials in the best way, how to work that into the management and best practices for doing this, training around the adverse events, for example, and the immune response criteria, patient access and advocacy, very important, and also very important coverage and reimbursement for these drugs that are expensive, and as they get approved, how are the payers going to address them? So early on, and this is late 2014, we did a survey of the members of ACCC to look at their familiarity of the concept of immuno-oncology. And only at that point, a few were extremely familiar with it, and the majority were somewhat or slightly, but about half the providers were only slightly or not at all familiar. Yet they all said that immuno-oncology issues were very important to a practice or cancer program. And so I think if we surveyed providers today, we'd see a very different kind of result. We looked at the challenges related to the introduction and the application of immuno-oncology with regards to patients. And most providers said that there were lots of issues: coverage and reimbursement issues, education and training of the staff, and patient education. And these remain issues that are important today and will be ongoing. So we've already heard 2 very elegant talks about these considerations for healthcare providers and patients. One, that response patterns differ compared to the response patterns seen with cytotoxic agents. And secondly, that these novel drugs have novel mechanisms of action, and these result in different treatment-related adverse events or immune-related adverse events. So that's from the provider view. This is what patients want to know. Is my cancer getting better or worse? And what kind of side effects can I expect? So I want to walk you through a real-world case example. This is from my practice. A 66-year-old woman who was symptomatic, had a CAT scan, showed multiple lesions. Biopsy showed adenocarcinoma, was treated with the standard at that time with platinum doublet therapy with a good response to treatment, progressed and received second-line small molecule TKI with some stabilization of disease and then progression of disease. So the patient was evaluated for an expanded access nivolumab trial, and this was initiated in November 2014. 1 week later, she was admitted to the hospital with increasing shortness of breath and nausea and diarrhea. She was treated aggressively, pulmonary measures found to have an infection in the urine, and luckily she improved symptomatically and was able to resume her therapy. The question is, could early reporting and evaluation of IO-related adverse events have prevented admission? And this is the type of example that goes on now every day when these agents are being used in the community. And as you heard, it's not necessarily a simple matter to decide whether the toxicity is coming from the therapy or coming from the disease. And each individual practitioner outside of a clinical trial has to make this decision on their own, which is a challenge. So here are the scans from this patient. On the left, you can see the baseline scans in November, and then the first evaluation, which was about 8 weeks later. And you can see in the top panel that the one lesion was stable, but in the bottom panel, you can see one lesion grew and there was a new lesion. So here we have to make this decision, as you heard from Jed, is this pseudo-progression or is this real progression? And how does the individual practitioner make this decision? This is not a trivial matter, and this has to be done with the patient. This is a shared decision-making process for sure. And in many cases, the patient gives the information here. So if the patient is getting better symptomatically, then perhaps it's more likely that this is due to pseudoprogression. But this can be a very challenging kind of opportunity. So this patient actually symptomatically was getting better despite the new lesion, continued on nivolumab, actually went back to work, was unable to work when first diagnosed or through her chemotherapy, both first and second line, and received 14 cycles of nivolumab. And you can see on the bottom the CT scan some 6 months after she was treated with nivolumab with 75% reduction in tumor size, and actually continues on therapy to this time, showing in a case what the potential is of these types of treatments in individual settings, but also the challenges. So what information do patients want, and what are they currently getting? This is a survey that was done by Cancer Care, one of the large support networks nationally representing patients. And this is some unpublished but in-press data that didn't look specifically at immuno-oncology, but this was a survey we did with several modules, including asking patients about diagnosis and communication and reimbursement. So this is from the communication survey that we did online with about 600 patients. And you can see here that a wide range of questions were asked. What kind of information did you get? So in general, patients did get information about their plans and their side effects and their symptoms. They were less likely to get information about the emotional impact of cancer and its impact on daily living. Less likely still to get information. About a third of patients got information from their providers on the cost of treatment plans. And I think disappointingly, and something we have to work on from a policy perspective, is that in this survey, only about 10 or 15% of patients got information regarding clinical trial opportunities. And as we heard yesterday, the field is still in its infancy, and for us to make progress in common epithelial cancers will likely require combination therapy. So we have to solve this issue, which is a longstanding issue, that only a small percentage of patients are even offered clinical trials, have access to clinical trials, and even fewer actually get on clinical trials. Now, the interesting thing about this survey is, as been seen in other surveys, is that there's a gender difference in how patients report the information they get. And as is typically seen, women are more engaged in the dialogue about information and tend to make the healthcare decisions compared to men. We drill down on some of the issues that cause distress in cancer patients. We saw, again, somewhat of a gender difference, but some of these issues, for example, side effects which cause distress, were well documented in general, but things like financial challenges and financial toxicity from therapies, particularly expensive therapies like we're talking about, were not addressed. And again, work-related activities of daily life, and end-of-life concerns are addressed in a very small minority of patients, something that, again, probably need to work on. Now, one interesting finding from this particular study was a difference in the way different groups react once they're diagnosed. So this question was, what of the following activities did you do within 2 months of learning you had cancer? And there was a group of young adults from 25 to 54 answered the survey, and this shows you in blue the African American responses versus the white responses. And you see, actually, interestingly, that the African American group were more likely to get engaged in a variety of activities, like talking to religious advisors, but also more likely to talk to other cancer patients, or to talk to a professional for emotional support, or to see another doctor for a second opinion, and joining a patient support group. So I think this is interesting data that needs to be fleshed out further. And it suggests that as we're talking to patients, that the way we talk to them and the language we use and the concerns they have may be different for different racial groups and different ethnic groups. So another group that we work with is called IO-ICON. This is an initiative that was started by BMS to bring together several of the large networks around the country to work on immuno-oncology, and it includes the West Cancer Center where I work, and US Oncology, the UCLA network, and Sarah Cannon. And we're working predominantly on clinical trials, but also on pieces of getting the information out to extend what Jed was talking about. So one of these pieces is an education committee that looked at creating educational resources for patients. So as you well know, obviously, immuno-oncology is another pillar. It works differently than the other traditional types of therapies we use, and indirectly affects cancer by working through the immune system. So these educational resources were created with community cancer nurses, and these were validated through online surveys, and we received comments from cancer patients and caregivers regarding the kind of information they were getting and how it would work. So we had 3 different scenarios that were fairly simple and graphically attractive, and patients were and caregivers were queried on which one they liked: the analogy of the seesaw, the analogy of the garden, or the analogy of the robber and detective, in terms of the way that immuno-oncology worked. And we saw that there were preferences for the first 2 in this case. There were variations depending on age, interestingly, on which one they liked. And there was some qualitative feedback, which was very useful in order to define which of these kinds of analogies we would use in the final product. So this turned out to create a resource, a Patient Caregiver's Guide to Immuno-Oncology, which was paper-based, gives space to take notes, with a calendar for their schedule for getting treated, and variety of topics are covered, including how it works and the side effects, and how do I play an active role in treatment. I think this is really critical. Patients want to play an active role in their treatment. They want to be engaged, and one needs to give them an opportunity to do this, and need to give them an opportunity to get more information, and importantly, what kind of resources are available for them to cope. So this is what the guide looks like. It includes the garden analogy to explain how IO works. It includes a bug bite analogy to explain the non-conventional pattern of response, and it uses iconography and simple line illustration throughout. It's for healthcare providers to use with their patients. And in progress now, for the next iteration, is a wallet card that patients can have. So if they do have to go to the emergency room or to the hospital, any of the providers will understand what they're on. And working on materials which are geared now for other members of the healthcare provider team, like social workers and navigators. So you've heard quite a bit on the adverse events. And again, there are a variety of IRAEs associated with the checkpoint inhibitors. And as you also saw, the time to these events can be prolonged. And this is from a study that looks at the difference between ipilimumab, the CTLA-4 inhibitor, and pembrolizumab. And you can see that actually even very late events can occur that are immune-related, going out to 200 or 300 days. So even at close to a year on therapy, one can see this. And managing these side effects take care coordination, a nurse to assess for the AEs, and an algorithm, and communication after treatment. Some of these side effects can actually occur late. So how can we best look at adverse events in the future? And one way to think about this is to use electronic patient-reported outcome systems, and I believe it's time for routine use. So this is an important trial that was just published a couple of weeks ago in JCO by Ethan Bash and Deb Schregg, who's in the room. And basically here, this was looking at an electronic system to assess 12 symptoms in patients in a randomized fashion in a single institution. And the endpoint of the trial was quality of life at 6 months. And it turned out that the quality of life was better for the patients who were assessed routinely with the electronic PRO system. And interestingly, as you see on the right here, there was actually, for the patients who were in the experimental group who got the ePro system, they were less likely to go to the emergency room because of using the system. And most interestingly, the patients, this was stratified by whether patients were computer experienced or computer inexperienced. It turned out that the computer inexperienced patients were more likely to derive benefit with regard to going to the emergency room here, which sets up some interesting hypotheses. So our group has been involved in the ePro world for a long time, and we developed a system called Patient Care Monitor, which reports physical symptoms, functional status, and psychological status. It's a complete review of systems, initially defined at the point of care. It takes about 7 minutes to complete, 56 items in the current iteration. We have 14 years of experience, and this has been deployed in multiple sites in the community and academic systems, and over 100,000 patients have completed it. It's been validated from psychometric and usability aspects. In fact, Amy Abernethy had the system in Duke for some time and did most of the validation work. And it can be deployed directly into the electronic medical record, and this shows you in a flow diagram some of the items and some of the visual prompts that highlight severe problems or symptom history. And the system has now been deployed as a web-enabled, cloud-based system that works on any mobile device. So it can prompt scheduling as it relates to immune therapy, and patients could report new or worse AEs depending on the particular level you want to look at, and then tailored notifications to the care team can be delivered by text or email, and patients can be contacted between visits to assess further and provide education and medication. The goal of ePros is to keep patients on treatment and out of the hospital. So finally, I just want to mention about patient access. And this was an interesting quote by one of my colleagues. There's no referring it away. This technology is going to be and needs to be available to every practitioner. And the question is, though, will there be different levels of care? So there is variation among sites for delivery immuno-oncology. And I want to just call your attention to the fact that the way cancer care has been organized in the United States has changed pretty fundamentally over the last decade, partially driven by reimbursement issues. So academic medical centers represent about 20% of the care of patients, and the other 80% is done in the community, about half of which is in large community practices, which have been aggregating over the last few years with 10 or more physicians, and then still 30 or 40% of practices, small community practices. And these vary in the way they approach patients and the way they are focused on research and their expertise and whether they're subspecialists. So there are challenges here for coverage, for example. So you heard about the adverse events. Patients don't like to report it. They usually call at 5 o'clock on Friday because they've been dealing with the event all week, and now they're getting nervous that the weekend is coming. So a lot of these patients get admitted. In an academic center, if you're on the melanoma service, you're covered by the melanoma service, and you know exactly what to do. In a large practice, you may be covered by someone who has no experience with this. So there are issues here, and there are reimbursement issues as well. So how will patients have access to these emerging technologies? The checkpoint inhibitors are broadly available. How are we going to get patients adaptive cellular therapies? We heard about the manufacturing from Mark, but how do we get this to the community? How do patients have access to this? Will it be like bone marrow transplant, with only certain centers doing it, or can it be more broadly distributed? So ICLEO finally is working on this, and there are many resources, much like you heard about from Jed, and very parallel to that, national conference, white papers, and seminars. And again, the ICLEO effort is being advertised in journals and to patients and providers. So thank you.